The information in this presentation is adapted from a chapter in UNCRID. You're not responsible for reading this chapter. There's lots of other information that I don't think you need to be aware of at this point. The only thing you're responsible from in this chapter are pages 197 through 200, and those mostly talk about ideas for promoting neuroplasticity in your patient populations. Working with patients with neurological injury, there are 4 different treatment strategy categories. Those are neuroadaptation, habituation, substitution, and compensation. Compensation training would be the use of an assistive device or an orthotic because the person with injury has a permanent condition that isn't going to be fixed. An example of this would be a patient who had multiple sclerosis and they had terminal foot drop. That person would require an AFO in order to compensate for the impairment. Substitution training is teaching your patient to use a different body part to accomplish the same task. For example, if a person has had a stroke and they have right hemiparesis in their upper extremity, if they were asked to open a bag that would require them to ordinarily use both hands to pull the bag open, they might choose to use their left upper extremity and possibly their teeth to get the bag open. They would accomplish the task, but they'd accomplish the task substituting one body part for another. Habituation training most commonly is used when working with the vestibular system. With habituation training, you're going to have your patient repeat the activity over and over again, such as turning the head to the right over and over with the hope of reducing the nervous system's response to that movement. And finally, neural adaptation. Neural adaptation is driving changes in structure and function of the nervous system with repetitive, attended practice that is task-specific. The majority of what I'd like to teach you in this course is going to be focused at neural adaptation. The role of PT in training patients with neurological injury is going to vary depending on the problems or the impairments that the patient is having, as well as their ability to function. PT could provide a functional role just by asking the patient to do an activity or a task-related activity over and over. An example of this would be having a patient walk with a straight cane, and you're just providing supervision if the patient is able to do the walking. An example of a role of a PT that's impairment-based would be if your patient has weak quads, having the patient sit on the side of a mat and just perform long arc quad sets over and over again. That would be impairment-focused, and it would be focused on strengthening the quadriceps muscle, just basic strength training. Another role that you could have would be augmented facilitation specifically, and this is what we talked about in lab earlier in the semester, using our hands or body overall and where we contact the patient to get the muscles to fire. Augmented facilitation training is something we'll be using a bunch in this class. And finally, there's somatosensory training. Oftentimes, it's noted that patients are more focused on the motor system recovery and not the sensory system recovery. So somatosensory training would be providing different sensory stimulation to the patient in the hopes of recovering that sensation as well. The general factors affecting motor learning can be divided into 2 main categories. The first are the cognitive factors. We already talked a little bit when we spoke about the limbic system, the importance of arousal, attention, motivation, and the 2 types of memory, both the declarative versus the procedural. Memory can be also further divided into verbal memory, remembering things that you've heard, visual memory, remembering things that you've seen, or kinesthetic memory, remembering how to do something or how you move when you learn. The motor factors, I think this should be a little bit of a review. Motor factors include the type of movement required, the practice schedule that you're going to use, the type of practice, the type of reinforcement that you provide your patient, as well as the environmental context in which you perform the activity. The next few slides will go into these motor factors in a little bit more detail. First, we'll talk about the type of movement. If the type of movement or the task that you're requiring the patient to do is a simple, discrete task, then the learning method that would work best would be whole learning. Whole learning would be demonstrating the activity or the task to the patient and then having them do the whole activity over and over as a way of learning and practicing. This would work really well with something as simple as sit to stand. Simple, discrete task. You demonstrate, talk about the steps, and then have the patient perform this in its entirety. Now, if the task were more complex, an example of a complex task would be walking or ascending, descending steps. The type of learning method that might work really well with a complex task would be whole, part, whole learning. Whole, part, whole would be the therapist demonstrates the task, demonstrates what you want the patient to do. The patient might actually try the whole task in the beginning, and then the therapist would break the task down into different parts. So, for example, stance phase on one lower extremity and swing phase with the other lower extremity would be two discrete parts that the patient could practice with both lower extremities. And then in the end, once they got each part down, then you would practice the whole thing and end up with the complex task of walking. A serial task, similar to the complex task, you would use something called progressive part learning. With progressive part learning, each individual part is practiced and added onto. So, for example, let's say ascending, descending steps. The first thing you would have the person do and learn would be, say, stepping up on the step with your right lower extremity. And you would continue to do that task until the person got it. And then the next part of the serial task would be to shift your weight up onto your right lower extremity, followed by bringing your left lower extremity up on the step. And eventually, if you did that serial task over and over, you would eventually ascend the steps.
We also have to consider the practice schedule. Two different kinds of practice schedule. The first is known as massed practice, and that refers to learning and studying conducted less frequently, but for longer periods of time. So, for example, with mass practice, you do something once a day for an hour at a time. Okay, that's in contrast to distributed practice. And distributed practice is a learning method in which information is reviewed for short durations over an extended length of time. So, for example, distributed practice would be doing something 4 times per day for maybe 15 minutes a session, as opposed to the mass practice 1 time per day. And the literature is actually very clear that the distributed practice is superior to mass practice for long-term learning and retention. And again, this is something to consider when you're designing intervention plans for your patients with neurological injury. And then finally, we have block practice versus random practice. Okay, block practice is the kind of practice that involves presenting the same activity over and over and over again before shifting to a different kind of activity. In contrast, random practice includes presenting activities in a completely random order. So instead of doing one activity for any length of time and then switching to a different activity, you do one activity and then another activity and then go back to the first activity and so on and so forth. Both of these practice schedules are good for patients. It just depends on what kind of goal that you're looking for. Okay, patients, if you're teaching patients using a block practice schedule, this actually improves learning quicker, but the random practice slows learning, but is better for retention and transfer of the learning. So, for block practice, people will learn the skill faster, but if you want them to retain the skill and transfer it to other activities, you might want to consider random practice. So next, let's consider the type of reinforcement or the type of feedback that you're going to give your patient. And in general, there are two types of feedback. There's intrinsic feedback, and this kind of feedback is provided by the movement itself. For example, there's proprioception information about where the right lower extremity is positioned in space, and this is relayed to the CNS or central nervous system during gait. Okay, that's intrinsic feedback, and this is in contrast to extrinsic or augmented feedback. There are two kinds of extrinsic feedback. There's both knowledge of results and knowledge of performance. Knowledge of results can be provided by a clinician to a patient performing the motor task of walking. If the instructions of the therapist to the patient were to walk across the room without losing their balance, and the patient was able to do this, then they achieved the end result. This would be knowledge of the result. The therapist may tell the patient, okay, you achieved the end result, good job. This would be knowledge of results. Can be kind of obvious to the patient that they did it, but the therapist can be there to also tell the patient that they achieved the end task. This is in contrast to knowledge of performance. And knowledge of performance would be appropriate if the therapist is working with the patient on the quality of their gait. The patient might be able to walk across the room, but it might not look normal. While the patient has completed the task, the therapist should comment on the functional movement patterns used, not just the end result of making it to the other side of the room. Okay, moving on. Let's consider feedback schedules. So there's different kinds of feedback schedules that you can use for extrinsic feedback. The four that I want you to know are listed here. And the first is continuous feedback. And this is feedback after every trial. Every time the patient is going to do something, you're going to give them lots of information either about how they achieved the end result or how well they did the task. And in general, continuous feedback is good for the cognitive stages of learning, but not very good for later stages of learning. You could also use fated feedback, and this is where feedback is given more often early on in learning stages, but then it declines in the later stages of learning. And there's also bandwidth feedback, and this is the kind of feedback that's only given for big mistakes. Okay, let's say that the patient's gait pattern is okay for the most part, but they took a wild step and they scissored and they almost lost their balance and hit the floor. So this would be an example of a time where bandwidth feedback might be a good idea. And then finally, there's summary feedback. And this is feedback only given after a group of trials. So for example, the patient is asked to walk across the room 4 or 5 times, and after that group, the therapist might then give feedback on their walking. In general, you should know that the higher frequency of feedback leads to better performance in the moment. However, as the individual progresses to the associative and autonomous stages of learning, then you should decrease the frequency of the feedback to promote long-term retention of the motor skill.
One final point to consider for effective motor learning is environmental context. Environmental context literally refers to the environment in which the patient is performing the activity. Early on in the recovery from neurological injury, either stroke patients or patients who've had a brain injury, it's going to be important to use an environment that is non-distractible, where distractions are limited. You can go into a private treatment room and work with the patient. And this is an example of a closed environmental context or a closed environment. working with the patient here. This is not close to a real-world situation where you have flat surfaces, you have mirrors available, there are no distractions. You can work comfortably getting the patient his functional skills back, his or her functional skills back. As the patient progresses in their motor learning, then you want to transition to a more open environment. An example of an open environment would be taking the patient out for a walk on a gravel surface or a grassy surface, something that isn't a smooth, manicured surface that they have to walk on like a gym floor. The open environment is going to be more real-life situations. This is also important in response to the patient's goals. If the patient has a goal of being able to go fishing again one day, and they're going to be standing up on a boat, you need to start practicing situations or environments that are similar to the rocking nature of the boat if the patient is going to achieve their goal. Principles of experience-dependent neuroplasticity. I'm assuming this is a review from you. This is from the Climb article. Specific principles are use it or lose it, use it and improve it. Be specific. Repetition matters. Intensity matters. Salience matters. Think limbic system. Age matters. Transference can happen with different activities that are similar, as well as interference can happen if a person, and this is particularly important if you haven't gotten to work with this person and they've been on their own for 3 months. They may have learned to walk, but that walking doesn't look anything like it should, or would not resemble a normal gait pattern. Patient expectation matters, and feedback and reward matters. Overall, the reading that I gave you for this chapter is just one table talking about these factors and looking at different ways that you could integrate it into therapy with your patients.